Thank you, and congratulations to PCC on 20 years of making a difference to the lives of patients as well as their families. And now, ladies and gentlemen, we're going to jump straight into the first panel discussion today. I'm going to tell you about it. The title is Many Minds, One Goal, bringing together the right team for every patient. Cancer care today is no longer driven by a single doctor or a single treatment approach. It is a coordinated effort bringing together different specialists, each offering a unique perspective to ensure that every patient receives a treatment plan that is not only clinically sound, but also personalized to their condition, goals, and overall well-being. And now I'd like to invite my esteemed panelists up on stage. They are Dr. Richard Quek, medical oncologist, Dr. Melissa Teo, surgical oncologist, Dr. Ivan Tham, radiation oncologist, and Dr. Peter Goh, interventional oncologist. Please take your seats, doctors. I'm right here. Yes, over there. So, my guests here, ladies and gentlemen, represent the 4 pillars of oncology, and that will be medical, surgical, radiation, and interventional. To make it easier, let's talk about the QR code. You will see the QR code on the right side of the stage. That is for you to scan if you would like to ask questions later on. We have 2 ways for you to ask questions. One, stand up. We'll do it live. And I think we would like to take some questions from the live audience here as well. That will be at the end of the discussion. If you would like to ask via Slido, some of our online guests will be doing that. Feel free to scan the QR code now. And so our doctors are very busy. I know some of them literally rushed here from their morning clinics on a Saturday morning, ladies and gentlemen. So we want to get the most. Thank you. We want to get the most out of them. Here's what we are going to do. We have decided to anchor today's discussions around 2 patient profiles so that it is easier for lay people like us to understand. So let's take a look at the slide for the first patient profile. Okay? The first case, we have a male patient in his 60s and was diagnosed with a rare and specific condition called GIST. The gist of it all, GIST. That stands for Gastrointestinal Stromal Tumor. Okay, Greek to us people. But let me invite the primary caregiver, Dr. Richard Quek. Dr. Quek, if you will, give us some background on the patient, please.
Okay, thank you so much, Diana. All right, so this is a man in his 60s who came to see me. He presented with reflux symptoms, so acid in the mouth, acid in the taste, for about 1 year. And this was about a year ago, February 2025. He did a scan, and there was already a fairly large tumor inside his belly. 17 cm is the size of a football. Just imagine a football inside the tummy. He was offered surgery, but he declined. For whatever reasons, he declined. And then he waited 2 months, and this was the time he had a biopsy. And the biopsy confirms an unusual tumor. This is called GIST, gastrointestinal, a GI tract tumor, stromal tumor. And this is a bit different from your usual stomach cancers, which are a little more crazy, a little bit more aggressive. And so he sat on it, and literally the mass continued to grow. And by now, it's 23 centimeters, and it's no longer operable. 23 centimeters is huge, I would say, maybe a watermelon. And therefore, the local doctors who was managing started him on a medicine, a very common medicine for this condition, with a success rate of maybe 70-80%. And he came over to the Parkway Cancer Center. He saw me, and he knew that I was interested in this topic. And so, when I see him, I did a scan, and this is what I see on the scan. And I'm going to hand over to my team, Dr. Peter Goh, who's a radiologist, and we just like to give everyone a snapshot of what we do in our clinics. A lot of times you just see the doctor, but back end there's a lot happening, and this is what happens on the back end. A scan was done, and Dr. Peter will be here to help us read the scans.
Dr. Goh, before we move on, can I just check very quickly, between February and May, I think the first check was February, it grew by a fair bit. That would be considered a condition that is very aggressive.
Yes, you're right, Diana. So in GIST, they usually don't grow so quickly, so I was a little bit surprised as well. Tumors tend to grow, this one tends to grow, but the speed is a little bit faster than I had liked, actually.
Okay. Yeah. Dr. Goh, please go ahead.
Thank you, Diana, and thank you, Richard. Good morning, everyone. What you're looking at with the color picture on the left of the screen is known as a PET-CT scan. And this basically is a scan to pick up areas which are very metabolically active, meaning cancer cells. And when they're replicating very quickly, there's a high metabolic rate, so it lights up as color. So what you're seeing with the arrow is the large mass with the color along the margins. The picture to the right is called a coronal reconstruction. That means it's a CT scan, but it's done in a way like we are facing each other. So it's from a lengthwise viewpoint. And you can see the huge tumor in the center of the abdomen. I think it's so large that I don't really need a pointer to show it. Yeah. So, thank you. So for the biopsy, it's very important that we get adequate tissue for the oncologist to know what he's treating. And that's where the role of the radiologist comes in. One of the things that we do in interventional oncology is image-guided procedures through needles under CT guidance or ultrasound guidance. And it's very important that I biopsy only the color portion of the tumor. Because if I were to put it into the central gray area, that's dead tissue and it's not going to give us much information. So under scan guidance, a needle is put in to the colored portion of the tumor, and we take the specimens so that we get adequate specimens for a diagnosis to be made by the pathologist, and Dr. Quek will know what to do after the results come back. Thank you.
Actually, a lot of times we do a biopsy. In this case, that we have an answer, but the common question I get a lot in the clinics is, will there be a risk of spillage of the tumor? Will you burst the tumor and as a result spread the tumor? What are your thoughts on that?
In general, the answer is there is a theoretical risk, but if you look at the overall spillage rate or tract seeding rate, that means tumor cells following the needle track out onto the skin surface, it's something like 0.02%. That's overall for every type of cancer that's biopsied percutaneously. However, I must say that there are always exceptions to the rule. There's always a chance that there are more aggressive tumors which tend to spread very easily. So there is always that chance, but it's a relatively low risk.
So can I just jump in very quickly? Dr. Quek, you had mentioned that you had asked if there was a chance that the tumor could be burst. Because we are lay people, to me, when you burst a balloon, everything spill over already. So how does it work with tumors? Does it mean that once you burst it, it's a slow spread or is an immediate contagion? How does that work?
Okay. So if you burst a tumor, the first thing one of the things that may happen is that tumor may bleed. And if it bleeds, the whole field is contaminated. So the whole belly is contaminated with tumor cells. And that's no good. That's, of course, it's a disaster. So if there's bleeding, then, of course, you have to bring in the surgeon, who's my colleague here, to come and save the day, stop the bleeding, do something about it, maybe emergency setting. Those are, again, not favored.
Maybe I can jump in here before I hand over to you, Melissa. So as a radiologist, we don't cut. Everything's done with a needle. So for me, when I do a biopsy such as this, to reduce the risk of bleeding, before the needle comes out, the needle track is plugged with a special type of gel to reduce that risk of bleeding. Once we started this technique of plugging that track, the risk of tract seeding and extensive catastrophic bleeding has dropped dramatically. The other thing about tract seeding, of course, is that in a tumor that's very large, if they're going to be started on chemotherapy anyway, the seeding along the needle track is also going to be treated along with the tumor. If surgery is in the cards, usually what I would do is I would coordinate with the surgeon, and they will know exactly where the tumor track is, so that if necessary, it can be resected at the time of surgery.
So in the case of this patient, after the biopsy was done, the results and the interpretation of the results would have been shared with Dr. Quek yourself. And what does the medical oncologist do at this point?
Okay. So that's when the back-end team convenes. So once either myself or the surgeon who sees the patient or the radiation oncologist who gets the patient first have confirmed the scans, have confirmed the histology, the diagnosis, back end we have a discussion. And this is a multidisciplinary discussion where we decide what's the best treatment for this particular patient, not any patient, but this particular patient in the context of age, the medical comorbidities, the medical issues, the size of the tumor, the location, and we come up with a plan for this patient. In our practice, we work very quickly because we have worked together for many, many years, even decades, and the communication goes very, very quickly. A lot of times it's a phone call, WhatsApp, group chat kind of thing, and we can snap and answer very quickly for the patient. We convene and present a multidisciplinary plan to the patient. And that's what happens on the back end.
So I want to jump in here and, Richard reveals our age when he says we've worked together for decades. Unfortunately, that is true. And I think I also want to emphasize what he said earlier about the discussion even before the patient has a biopsy. So very often you see one doctor, but actually there's a lot of running around in the background. And most of the time, even before the biopsy is undertaken, we have a chat about what do you think is the best way forward. Some patients require a biopsy because before going in for surgery, we want to know what kind of a tumor this is and whether there is anything else that can be done to improve the outcome, like chemo beforehand or radiation beforehand. But some patients, we feel, okay, the tumor should come out first, and so we don't take on that risk in that sense of bursting the tumor, and we go ahead with the surgery. We have this discussion in the background because at the end of the day, different tumors have different kind of prognosis, and I think it's very confusing for a patient who goes, and sometimes you worry if you see a chemo doctor, he's going to tell you go and do chemo. You see a surgeon, then the surgeon says go and do surgery. But when we work as a team together, we really try to see in this particular patient with this particular kind of tumor, which is the best way forward to get the best survival. So that multidisciplinary care is really quite important. And even before they do the biopsy, highlighting it to me so that, the biopsy is going to be taking place on this day. If there's any complications, standby and all that, that's useful. So nothing needs to be done in a hurry. Everybody is already on standby and prepared. So I think that is a key thing when we are treating complicated tumors like this.
So if I can just jump in at the moment, I just want to be very clear. When we are talking about a multidisciplinary team, we are talking about a panel of experts that cut across different types of specialties that come together to work on a patient, right? To make sure that the outcome is as best as we can possibly get it, yeah? So that's what we mean. Because sometimes we drop multidisciplinary, it's like, what is the meaning? But basically, that's what we're trying to say. So I wanted to ask, in the case of this patient, he was referred for surgery. Would either Dr. Teo or Dr. Quek would like to say something?
Yeah, actually, so we did the scans, and this is the picture I showed just now. And the home doctors told him that this is inoperable, cannot be operated. Size of a watermelon in the tummy cannot be operated. And I know this patient has already seen the first-line medicine, which is the most effective medicine, and whatever medicine I have in my arsenal is not going to shrink it. All right, so that's when I'm a bit stuck, right? So, but I look at this picture, I'm not a surgeon. I always start the conversation by saying, I'm not surgeon. And because I'm not surgeon, however, I've seen many of these pictures before, I realized there's a little line between the tumor and the surrounding structures, which is where my dotted line is. And I said, actually, guess what? Maybe this thing is operable. I can see a little gap between the tumor and your vital organs. I think it's worth a consultation. And so that's when I called my fellow colleague, Dr. Melissa Teo. I said, could you have a look at this patient? I think it's operable from my untrained eyes. What do you think?
So Richard says he's not a surgeon, but he's almost a surgeon. He's done so many of these kind of tumors that, when he looks at the scan, he can sort of have an idea that it may be. And yes, 23 centimeters is quite big, but 2 weeks ago, I did a patient who was also told that he had an inoperable disease, and his tumor was 38 centimeters when we took it out. So, this is really not by far anywhere close to the biggest tumor that we have seen. A key thing is also the examination of the patient. I mean, when I feel the patient's tummy, we get a sense of whether things are going to be stuck to many organs or, stuck to one organ or so, and whether this is going to be something that we can take out fairly easily and safely. And of course, we gauged the patient's fitness for the surgery and all that. And on the clinical examination, I felt this was not difficult. Looking at the scan, Dr. Quek highlighted the dotted line at the back, which is true. We always look at the scan to see what are the organs that are nearby. And in this particular patient, there are a few organs that are potentially quite close. The blood vessel that is coming from the heart to the rest of the body, the blood vessel that goes to the heart from the rest of the body as well. The colon, the stomach, they are all close by. And when I counsel the patient, I tell them what are the things that can be taken out. Most of the time, I will give them an idea of how easily we can do this. Like, oh, in this particular patient, I told him I should be able to get the tumor out in 3 to 4 hours. I might have to take a bit of the stomach and the colon, but I think your risk of surgery should not be more than 2 to 3%. Now, 2 to 3% in 3 hours, for a patient, of course, when he was told previously inoperable, I mean, it sounds like pretty good. And we must also understand that in a patient with a tumor this size, he also has quite a lot of symptoms. You can imagine if tummy feels very tight, he cannot eat well, he cannot move around well, he cannot pass motion very well, and really has an impact on the quality of life. So, based on the clinical examination, based on the scan as well, and based on the tumor history, meaning to say that we know this patient already had first line, didn't really respond, and based on the fact that the patient had a lot of symptoms, we decided that surgery upfront would be a good option, and let's take the tumor out, and then we have the whole tumor for further analysis. So that's what we proceeded to do.
I think we have a picture. Shall we take a look at it? Yeah.
Yes, I hope.
So maybe summarize for us what...
Yeah, this is not the
What
worst
is this?
picture. So we recognize that it's a public forum. So, I have a lot more gory pictures if you ever wanted to look at my laptop. But you can see here, this is a big tumor. It's 23 centimeters. Maybe if I have a pointer, there are some intestines and all that on the side. But it's so sizable that you really can't make out. Fortunately, this tumor, unlike the tumor that I took out 2 weeks ago, didn't involve the kidney and all that. Sometimes they do. It just involved the stomach that is stuck right to the top end of the tumor there. And so we had to take a sliver of that, and then I think the colon on the right-hand side. So as you can see on the picture, maybe the next slide, if you look at, you can see that the tumor came out whole. And I think this is important because when you do an operation, well, for most cancers, and then particularly so for this cancer, you want to take out the tumor complete. You don't want to be taking out in bits and pieces. And very often, unfortunately, I see patients for second or third opinion, and they come to me and they give me a histology report, and they say, I had this tumor, initially said to be inoperable, and then I saw a second surgeon, then they went in and they took it out. He said, maybe clean, maybe not clean, and all that. Can you look at the report? And, we see the histology report, and the tumor is in bits and pieces, like chunks of the tumor, which is really not what we want. We want to take out the tumor complete and ideally with clear margins. So if you see that the stomach is involved, you don't cut right where the stomach is involved, but you give a little bit of a leeway.
Okay, so basically what we are looking at is a beautifully complete tumor.
Correct.
Okay,
Correct.
so you can really tell that Dr. Teo loves what she does. She speaks about it with a lot of passion. So let's say it's clear that the operation was a success. Yes. Correct? I think we have some scans of the after picture, Dr. Quek. Maybe in the interest of time, we look at the scans for the after. There you go. Is this the post-surgery? Let's talk about this.
Yeah, correct. So on the left, we have the pre-surgery, just to show that after surgery, everything is nice and clean. This is where he looks a lot better, I thought, after surgery, when his tummy is not so big.
Yeah, he looks great.
He looks fitter.
I tell him he has to make sure that he doesn't ditch his wife and move on to a new girlfriend. He had a spring in his step, and obviously this kind of a scan, you see the pre and the post, right? For me, this is very on-turning, but I shouldn't say stuff like that. But yes, this is the scan. You can see that the tumor is completely gone, the organs have gone back to the original position, the kidneys are intact and functioning very well, and he had a much better quality of life.
Okay, so we're very happy for this patient. We need to wrap this case, but Dr. Tham, if I can just come to you very quickly. You are a radiation oncologist, and radiotherapy was not required for this case. Would you comment on that?
Yeah, thanks, Diana. Yeah, so in many cases, there are pretty standardized protocols of what can or cannot be done, whether there's a role for any treatment before surgery or after surgery. So in this case, there's really no role for radiation therapy at this point. And if the patient had come to me, I would say, go and see Melissa. Okay. Conversely, there are patients who might benefit from some kind of treatment before surgery, in which case, like Richard or the patient comes to me, we again have a quick discussion, and if radiation is required, then we try and get things started quickly so that patients start to get some tumor response, and then they can go for surgery at the earliest available time.
Okay, so ladies and gentlemen, we are not teaching you how to perform surgery, because these are very clever people who have studied for many, many years, and I feel very guilty because sometimes when I interview the doctor, I will say, give it to me in a 1-minute soundbite, which I will then trim down to 30 seconds, and they have studied for like 10 years to get to where they are, right? But we just want to give you a bit of BTS, as the young people will call it, a bit of behind the scenes of what actually goes on, okay? So I know that Dr. Tham, the next case that we are talking about, Dr. Tham was intimately involved with it. So let's move on to the second case. If you guys will, can we punch up the notes for the second case as well? So are we looking at it? There you go. We have an 81-year-old man who was diagnosed with esophagus cancer. The esophagus is the tube that carries food from the throat to the stomach. Dr. Quek, do you start with this case as well, with the scans?
Maybe, yeah.
Or Dr. Tham will? Okay, Dr. Tham will take it away.
So just a little background. So now the previous case was a patient in his 60s. Now this patient is in his 80s, so fast forward 2 decades. He's generally quite fit, and he can go for daily walks and so on, though he does have some heart issues. He has had 3 stenting done since 2017. He does have an irregular heartbeat, which requires some blood thinners and rhythm stabilizing medicine, so on follow-up with cardiologists as well. This episode actually was picked up by the polyclinic doctor, so kudos to him or her, who noticed that his hemoglobin level, the amount of red blood cells in the blood, was actually dropping. Not very low, but still a trend downwards. And so he was referred for further investigations. He was referred to a surgeon, who then eventually went on to do a scope. So in many cases, when we have gastric symptoms, intestinal symptoms, we can get the gastroenterologist or general surgeon to do a scope to look into the throat, beyond the throat, into the gut, the gullet, on the way to the stomach. So this was what was done, and unfortunately it showed a tumor. You can appreciate the irregular growth that was in the lower part of the esophagus. So subsequently, he had some investigations, some scans, which Peter can give his comments about.
Thanks, Ivan. So the top picture is, of course, the picture of the cancer on the scope. The bottom 3 pictures is the PET scan. Again, like in the previous case study, the areas which are very metabolically active, meaning the cancer replicating cells which are very active, will take up a lot of the radioactive material and will light up like a light bulb. So you can see the red and yellow areas just in front of the spine and behind the heart. That's where the gullet or the esophagus is, and the bright colored areas are the tumor. Very important for all cancer patients for PET scan, because it tells us whether the tumor is just localized to the area of concern, in this case the gullet, or whether they're spread elsewhere. And that's one of the reasons why the PET scan is important, because it helps to stage the level of the cancer.
So with these images, Dr. Tham, what was recommended, the treatment plan? What was the treatment plan for this patient?
Yeah, so esophageal cancer can be quite challenging to treat. As Peter mentioned, the rate of distant metastases, that means spread, the risk of spread of the tumor beyond what we can see in the esophagus is actually quite high. So this patient had multiple lymph nodes. even some quite near the stomach, some distance away to where the primary tumor started. So it's a challenging case. It's what we would call a locally advanced tumor. There are various strategies to try to cure this patient, either surgical or non-surgical options. So he did see a few surgeons, actually 3 surgeons, but maybe let Melissa comment on.
So I think this is where, again, the multidisciplinary, meaning involvement of the radiation oncologist, the chemo doctor, the medical oncologist, the surgeon, the radiologist, and all that is really important. And also the pathologist, because when we look at the scan, we want to know, A, did it spread anywhere else? B, if it didn't spread anywhere else and it's confined to one area, is it still a very big do? That means this surgery going to be very aggressive, and can the patient tolerate it? And then C, what kind of tumor is it, and should we do surgery, or is there any other option if we are thinking that this surgery may be very big for a guy who has got multiple heart issues and all that? And the biopsy, later on, I guess they will discuss. But if it looks like it's something that may respond to something else, we may want to favor doing something else before surgery, or even as the definitive treatment. So, of course, looking at this particular one cut of the scan, I mean, I can see that it hasn't gone anywhere else. The tumor potentially can be removed, but with the fact that there are quite a lot of lymph nodes, we worry about how extensive the disease may be, and we worry that even if we take out the tumor, is he going to do well in the long run? And again, I want to highlight in an 80-something-year-old, and this is where we want to talk about very personalized approach to the patient. I mean, how we treat a 40-year-old may be a little bit different with an 80-year-old, but bearing in mind that at the end of the day, we want to give the patient that long survival and also the quality of life to do what he enjoys doing. So maybe you go on with the biopsy result.
Yeah. So this patient had a biopsy at the time of the scope, and it was shown to be squamous cell carcinoma. So it's one of the common subtypes we see in esophageal cancer. So we had similar discussions with the patient and family also had surgical opinions and so on. And in the end, they decided that weighing the cost, the benefits and the potential risks and so on, they were not keen to undergo surgery. Now, this patient was seen in 2023, which is kind of a landmark year for the IHH, because that's when we first had the Proton therapy service come on board. So this facility was the first to start clinical operations in Singapore in 2023. And I saw this patient just a few months after we started. So as you know, the ministry does have some regulations about who can or cannot be given proton therapy. So fortunately for patient, esophageal cancer was one of the first few indications that were allowed by the ministry. So we had this discussion whether he wanted to embark on this new therapy. It's kind of similar to the old radiotherapy that we have, but with added benefits in the sense that we can spare the heart and the lungs from extra or unnecessary radiation dose. So if I can just take you briefly through what we are seeing. So the top 2 pictures show the machine at Mount Elizabeth Novena. One shows a mock-up patient and 2 therapists attending to her. The below 3 pictures show what we call a dose plan. So the colors represent where our protons are landing. Okay, so the yellow areas are where the protons are landing 100%, that's where we want. And where there's no color, there's no protons. So the advantage of this compared to regular X-ray therapy is that we can program the protons to stop exactly where we want. So if we give the treatment from the back, it lands onto the tumor and it doesn't go into the heart. And as you recall, this patient's heart is not 100% healthy. Similarly, we don't need to go from the sides. So the amount of radiation, unnecessary radiation that the lungs receive is also quite little.
So maybe I jump in here just because you have such a beautiful image on the bottom row, left-hand side. You can see that the tumor is not a small area, but it's a very long area. And also that a big part of the tumor is in the chest, meaning to say behind the heart. So for a patient like this, if I'm going to do an operation for him, I would have to go, first I would make a cut into the chest, and I would get and dissect out the tumor there. Then I have to make a cut in the tummy to free up and also clear the lymph nodes, plus I have to move the stomach up into the chest so that I can use the stomach to reconstruct the esophagus. Then I will join the top end of the stomach in the neck to the back of the throat. So 3 cuts in an 81-year-old man with heart issues is possible. I mean, we've done that before, and certainly if he's a young guy, I would want to do that. But the second thing that I think we want to highlight is that, again, behind the scenes, he said that the biopsy showed a squamous cell carcinoma. And this is very important because if it had been another kind of cancer of the esophagus, maybe it wouldn't be so responsive to radiation. But knowing that it's a squamous cell cancer, we say, hey, this one can respond to chemo and radiation, so maybe this is a good option. So there's a lot of discussion to see how do we get the best survival for the patient and work with our colleagues to achieve that result.
Okay, we are running out of time, so I'm just going to say that from what you've heard from our panel today, the solutions and the treatment plans are actually really customized. And Dr. Teo herself has just said what you would do for a patient who is 41 years old and one who is 81 will be entirely different, right? So very often when I speak to family members and friends, I hear them say, hey, but I got one friend, he did this. So I'll be like, how old is your friend? Your friend will be 50 years younger. So sometimes we really need to listen with an open mind, particularly when we are talking to the experts as well. So cancer care is no longer about choosing one treatment over another, but rather bringing together the right expertise at the right time to design a plan that is truly tailored to each patient. Okay, that's what we call by a multidisciplinary team approach. So ladies and gentlemen, we do have time to take your questions. We're going to open up the floor for questions. Let's see, if you do want to ask a question rather, please raise your hand and we'll have the mic runners come round to you. And for those of you who are joining us online, I think you can key in, scan to submit your questions via Slido, and we will see if we can take a question. Anyone from the floor? We are going to prioritize those who are live here with us. Yes, we have a gentleman over there. I'll take your question on Slido next. So please introduce yourself, and if you have someone to direct the question to, please say so.
Good morning. My name is Lim. Lim.
Mr. Lim, yes, go ahead.
My question is, this cancer patient originally came from a polyclinic. So how did he eventually ended up in a private hospital?
Thank you, Mr. Lim. That is a good question. Would anyone care to reply, please? Who will take the question?
I can say a few words. I mean, actually, it's really hard to know because different patients have different patient journeys. In fact, just over 2 days, yesterday and today, I saw 2 different patients, both also in a public health system. The patient yesterday went to a public hospital and, of course, went through a couple of months of investigations and then was told that it was inoperable and he had 3 more months to live, and so he wanted to have a second opinion. Spoke to his friends, and he had a few friends who were doctors, and so they came to seek an opinion. And the patient that I saw this morning, exactly the same situation like this, went to the polyclinic, had a low hemoglobin or blood level, and this was about 6 weeks ago. Eventually referred to a public hospital, general surgeon did scope scans and all those things. But it has been 6 weeks and they haven't come up with a plan yet because they told her that it's very complicated and need to have quite a lot of doctors to meet up to discuss and so on and so forth. And so the children decided to bring her in for a consultation. So I think different patients have different journeys. Sometimes they present in a very acute fashion with an emergency and, they wait at the A&E for a long time. The public hospital is really good, but of course there are restrictions with, high patient load and sometimes a longer waiting time. And when the patient is suffering in pain, they waited there for a while, they want another option. Or, as every patient is entitled to, I think this is about their lives. When they are told something is inoperable or it's not, they want to know if this is accurate or not, and it's reasonable. And in fact, even when I see patients, and I'm sure all my colleagues here, we give them the patient our opinion, and we always say, ask all the questions that you want and be free to speak to whichever doctor in whichever hospital, public or private, to ensure that you feel comfortable with whatever that is recommended to you and you feel that this is the right decision. So I don't know whether in a very roundabout way we sort of answered that question.
Thank you. Thank you, Mr. Lin, for that question. Do I have another question from the floor? Yes, this lady over here. I have a question on the MDT, which is multidisciplinary team,
I'm
correct?
Susan. I'm a layperson, so pardon my ignorance. I'm just wondering at what stage is the stage of cancer being determined, and by what means?
At what stage is it determined and by what means?
Right. So usually when the patient first sees any doctor, it could be the surgeon, the radiation, or the medical oncologist, we will want to do two things. We want to establish the diagnosis. What is this that's happening inside the body? One. Number two, we want to know how extensive the disease has gone to, the spread. And that's when we do the relevant scans. It could be a PET scan, which we showed the colored one. It could be a CT scan, MRI, and those scans will be ordered by the doctor. And radiologists like Dr. Peter will then read the scans and tell us whether there's any evidence of spread. The spread will then determine the stage. In general, the stages are 1, 2, 3, and 4. The bigger the number, the worse it is. And usually when there's a 4, it means spread. That's the sort of the gist of what we do in our initial phase.
Okay, I do want to take one question from Slido, and it says, what is the one thing you would like us to know about MDT, which is multidisciplinary team, is that right? The MDT. Actually, let me just refine the question a little bit. Can the doctors here give me very specific advantages, what it means to me when my team of doctors is multidisciplinary? What does it translate to me as a patient?
I think I mentioned this briefly before. I mean, it's confusing for the patient when they have a diagnosis like cancer. It's scary, and the fear always is that they see a medical oncologist. The medical oncologist says, okay, start chemo immediately. They see a surgeon. The surgeon says, no, should do surgery first and all that. If you have, if your case is discussed in an MDT, which is what we always do, then it becomes a combined approach. And we are unified in our answer. So which means to say that in the first patient, although the patient saw Dr. Quek first, Dr. Quek said, wait, let me discuss with my colleagues. This is the plan of management. I'm also going to send you to see, Dr. Peter for the biopsy and Dr. Teo, myself, for consideration of surgery. And after we've chatted with the patient and we meet up again after the results, all of us agree, okay, this is the best treatment plan. So now the patient knows, not only does my interventional radiologist, my medical oncologist, and my surgeon, they all feel that surgery up front is the way to go. They can be confident that, it's not just one doctor that says this, you see. So the MDT really provides a unified approach to the patient's problem, giving them one united answer that takes into consideration the personalized characteristics of the patient, plus how to achieve the best outcome.
So does it mean that the patient eventually talks to one doctor and the doctor gives the assurance to say that I have spoken to all your other doctors and this is our consolidated advice and conclusion? Because it can be very, very tiring when you are seeing a doctor and 10 different people come in and ask you the same questions, right?
That's absolutely it. So the one doctor represents the group of experts in the particular patient's condition to present the best treatment for this patient. And I just want to highlight that this MDT must be done quickly. Can you imagine the patient has a cancer, is waiting for an answer, and if your meeting is a formal meeting once a week and you come in on a day after the meeting, you've got to wait 1 week for the meeting. So those are constraints that are present, and therefore MDT, let's say in our practice in the private sector, we tend to want to move things a bit faster, and so therefore we have virtual MDTs all the time. We have formal MDTs once a month. Peter and I lead the group. But for each patient, each case is informal, and the informality brings things forward. We get an answer within an hour, and we know exactly what we want to say to the patients next. So the speed matters.
Thanks. I'd just like to add, Richard, that we've basically got we're nimble. We're more nimble in private practice because we're all connected by the mobile phone. We don't have to make an appointment with another department. We are all linked up on computers so that we can review the patient scans at the same time. I can talk to Richard about his patient scan, and we are looking at the same scan at the same time, but we are separated. He's in Mount Elizabeth Novena, I'm in Mount Elizabeth Orchard. We can make a decision quickly. The other thing is, yes, usually one specialist to represent the entire team, but we are also open to take in-person consultations to discuss directly. For example, as an interventional oncologist, sometimes I can offer other treatment options besides surgery, such as burning or freezing the tumor with a needle and to save major surgery. And I will take a direct consultation with the patients to discuss this if they want to, or they can stick to their referring doctor for their opinion. So
Okay.
I think the nimbleness is a key point.
Would you like to say something?
And just to take a broader view about MDT, it's often not just about the doctors. So, for example, the patient with esophageal cancer, we got a dietitian to talk to him, to advise him, because he's losing weight, he has no appetite during the treatment. And similarly, many patients do need physiotherapy, occupational therapy, speech therapy, and so on. So it's also a useful resource in a comprehensive hospital to be able to tap on these other professionals.
Okay, got it. In other words, ladies and gentlemen, having many tualokun is better than one tualokun. Okay? So the tualokun is a Hokkien term for a big doctor, an important doctor. That's what in the olden days, as my kids would say, we refer to doctors who are very clever. Okay, ladies and gentlemen, I'm afraid that's all the time we have for the questions. Thank you for those who have posted some questions on Slido. For the rest of them who have not been addressed, we will be giving you the answers on our digital channels progressively, so do stay tuned to our channels. It leaves me now to ask you to join me to thank the doctors for their time and their sharing. Thank you very much. Thank you.